Well, I think we're going to go ahead and get started. Thank you for coming tonight. Appreciate it. Can I ask how you heard about it?
Facebook.
Facebook. Perfect. That's wonderful. It's my honor to introduce Dr. Sharita Nagaraj. She is a general surgeon here at Northern Arizona Healthcare and has been here for almost a year. And so I'm going to let her give a little bit of background about herself, and she's got a great presentation for you today. So
thanks, Penny.
Yeah.
So yes, thank you all for coming to this presentation on guarding your gut against colon cancer. A little bit about me. I am a general surgeon and started working here in May of last year. But I grew up in the Northeast and did all my education and training there, and that's also where I got my first job at Penn. So I've been in practice for about 10 years now, and I've performed at least a few thousand colonoscopies and a couple hundred colon surgeries. So needless to say, I've seen a lot of butts. So today I'd like to demystify and perhaps destigmatize this part of the body, which a lot of people feel embarrassed to talk about, let alone have examined. But it is so important because colorectal cancer is a leading cause of cancer and cancer-related death in the US and worldwide. And these are just some photos from the beautiful Northeast in the different seasons. So what is colorectal cancer? First, a quick anatomy lesson. So the colon is the large intestine, pictured here. And it's about 5 to 6 feet in length. The rectum is about a foot long. There's a lot of other small intestine that's here on the slide, but for the purpose of this talk, we'll be focusing on the large intestine here. And the purpose of the colon is to reabsorb water and electrolytes from food that you eat. It concentrates that material into stool, and then the rectum stores it until you're ready to go to the bathroom. So while the colon and rectum have different anatomic and physiologic roles, they do share some similarities with respect to cancer development and management, which is why we consider them together when we talk about colorectal cancer. So what is cancer? Specifically, cancer is the uncontrolled growth of abnormal cells, and it's usually due to a mutation in the DNA of those cells that allows it to grow out of hand and eventually acquire the ability to spread to other parts of the body if left unchecked. That spread can result in invasion of normal tissues and organs in other parts of the body. With respect to colon cancer, this growth always manifests as polyps. So this diagram on the right here is known as the adenoma-carcinoma sequence. Adenomas are polyps that have the potential to grow into cancer. Not all of them will. Carcinoma is just a fancy word for cancer. But there are also polyps that are completely benign. So that's your polyp that's all the way over on the left here. That's just hyperplastic, hyperproliferative. That will never grow into a colon cancer. And not even all adenomas will grow into a colon cancer. About 5% of them ever do. But all colon cancer and rectal cancer starts out as a polyp, which is why it's important to get screened to find those as early as possible before they develop cancer within them. So what are the signs and symptoms of colorectal cancer? It's unfortunately usually asymptomatic in its early stages, so most people don't realize they may have it until later on. Those symptoms can include blood in the stool or a toilet bowl, and usually that blood is going to have a bright red color or a maroonish color to it. Blood from higher up in the gastrointestinal tract usually turns black by the time it ends up in your stool. Your stool can look pencil thin or like ribbons coming out, kind of stringy. If that cancer has formed a mass that's kind of obstructing the lumen and thinning out the stool as it comes through. Sometimes people have rectal spasms with rectal cancer. It's very painful, kind of a throbbing like pain internally down lower in the pelvis. Bloating and abdominal cramping, which unfortunately, it can be kind of non-specific. A lot of people have that depending on what they eat. But if it's new for you, persistent, definitely something to have checked out, evaluated by your physician. Unintentional weight loss. Sometimes we don't know why people are rapidly losing weight, but if you have the same diet, same amount of activity, and all of a sudden you're losing pounds within a short period of time, you want to get checked out. And one of the first tests you might do if you haven't had it done yet is a colonoscopy. And then lastly, Anemia, which are low blood counts, that can be an indication that you're losing blood from somewhere in your gastrointestinal system. That'll come up with routine blood work that your doctor might order for you, and they would refer you to either a gastroenterologist or surgeon for screening at that point. So why are we focused on colorectal cancer? Well, aside from March being the month for awareness for colorectal cancer, it's unfortunately an important cause for morbidity and mortality, and it is also one. So my goal today is not to scare you about it, but to empower you to take control of your gut health. We don't recommend screening for all cancers. There are only a few that meet that criteria for screening, so breast, prostate, cervical, colon, and sometimes lung. And one of the reasons we do that is because these are very common cancers. Colorectal cancer is fourth most common cancer in the U.S. as of 2025. Previously was the third, but it is the second leading cause of cancer death, and that's often because it's not detected until later stages. Unfortunately, we're also seeing an increased incidence in younger age groups, meaning under the age of 50. This graph here is from the National Cancer Institute database and shows that increasing incidence in patients who are under the age of 50, and it has nearly doubled over the last 2 decades. Good news is that the overall incidence of colorectal cancer has been decreasing over time, as has the mortality from the disease. This is thought to be due from increased rates of screening. So we are catching these at an earlier stage, and therefore we're able to cure people of the disease. When we stratify colorectal cancer by age, we find that so 65 years of age actually have the most dramatic improvement in that incidence, as well as improved mortality from the disease. And that correlates with their rates of screening. They have highest rates of screening. Unfortunately, younger individuals who are under the typical age for screening, or pretty busy, 45 to 50 years of age, that's where we see our lowest rates, have that highest incidence. And again, we think that's because they're not getting screened as much. This shows that the screening rates are increasing, which is great, but we still have some work to do. The national goal is actually to get 80% of all adults in the US screened. I don't know why it's 80 or who picked that number. It should be 100%, obviously. But we do see some improvement, unfortunately, in this youngest age group here, 45 to 49, even though 2019 was the year that the American Cancer Society lowered the age of screening from 50 to 45. Even then, we're still seeing rates of only about 30. They might have increased a little bit since then, but still a ways to go for that younger age group where we see that incidence rising. So we know that the earlier we find colon cancer, the higher the chance of survival. This chart shows 5-year survival for different stages of colon cancer. Stage 1 and 2, which are considered localized, it's localized to the colon, hasn't gone to the lymph nodes or other parts of the body, has a very good survival rate, over 90% with treatment. Once it's gone to the lymph nodes, that rate does drop down to 75%. It's still decent with the amount of treatment that we have available. And unfortunately, once it goes beyond that, we see our survival rates drop. So the point here is to understand that finding this as early as possible gives you the best chance of a cure. So one of the most common questions I get whenever somebody comes to my office with a new diagnosis of cancer, no matter what kind, is why. Sometimes that's an existential question, as in me, but a lot of times it's what caused this? Did I do something to get this cancer? And I try to reassure patients that even though we do know risk factors for colon cancer in any individual case, we can't really say exactly why you developed the cancer. You could have the lowest risk possible. You could have modified all of your risk factors and you could still get it. So it's important, if that is you, not to blame yourself. Typically, cancer is going to be caused by a range of different factors and the interactions between them. But that said, we do have some solid evidence that underscores risk factors for developing colorectal cancer, and certainly some things we can do to significantly reduce our risk and improve our chances of survival when diagnosed with it. So I'm going to go through first things that you cannot change. Why do I go through those? They're fixed things that are inherent to your body, but it's important to understand kind of what your individual risk is and how that might impact your screening recommendations. And then I'll review things that we can change, have power to change. So the things that change our age. Of course, we're all going to grow older, and with time, the incidence of cancer increases because our DNA changes. It breaks down and we acquire mutations, and some of those can be cancerous. So as we grow older, that's why it's important to understand what are the cancers that we can screen for and make sure we're up to date with those screenings. Family history and genetics does account for a significant portion of colorectal cancer, specifically family history, even if there's no known genetic mutation associated with that. So what is a significant family history? That's if you have a first-degree relative, typically diagnosed at a younger age, that's more likely to be hereditary. So if you have a mother or a sibling or even a child that's been diagnosed before the age of 60, then you would be considered at an increased risk of developing colorectal cancer. And you want to talk to your physician about how that might change your screening protocol. Even when there is a family history, only about 5% of colorectal cancers will have a genetic mutation associated with them. And there's the two most common hereditary syndromes with colorectal cancer are familial adenomatous polyposis, which is associated with mutation in the APC gene, and then another syndrome called Lynch syndrome. So if you've heard of these within your family and you think you might have them, those are things to get tested for to better understand your individual risk and how that changes screening for you. There's certain populations that have an increased risk, notably Native Americans have the highest relative risk compared to the average population, as well as African Americans. And people with Ashkenazi Jewish backgrounds also have an increased risk. People with a personal history of inflammatory bowel disease, such as Crohn's or ulcerative colitis, as well as a history of abdominal or pelvic radiation. For example, women who might have had radiation for uterine cancer in the past also have an increased risk of colorectal cancer. And if you've ever been screened before and they found polyps, specifically adenomas on your required colonoscopies, you might know that your doctor has recommended you come back in a certain amount of time, usually less than that 10-year interval, to be screened again, because it does put you at risk for developing more adenomatous polyps as well as colon cancer down the line. So these are the things you can't change. Important to keep in mind if any of these things apply to you. You should talk to your doctor about when you should start getting screened and how often. And there are the things that you can change. We're going to go into some of these things in more detail on the following slides. That includes diet and how fiber, processed foods, and meat can increase or decrease your risk. Alcohol use, smoking, excess weight, and type 2 diabetes. So fiber is incredibly important. There's a plethora of evidence in the literature that diets high in fiber are associated with a decreased risk of colon cancer. And even some evidence to suggest that a high fiber diet may improve survival for patients with colon cancer. There are two types of fiber. There's insoluble and soluble fiber, and they work in different ways to help decrease that risk. Insoluble fibers come from grains and cereals in your diet. That cellulose, for example, it doesn't really get absorbed or broken down, but it helps to kind of carry things through your intestine and speeds up that transit time. So any carcinogens that might be present in your colon have less time in contact with colon lining and less time to do damage. Soluble fiber is fiber that might be found in fruits and vegetables, and it's food for the good bacteria that live in your gut. We all have a number of different types of bacteria in our gut, and we want the good bacteria to thrive. So feeding them with fiber helps that. When they eat fiber, they produce short-chain fatty acids. These are compounds that are formed as a byproduct of the bacterial digestion of fiber. And one of the most studied is a compound called butyrate. Butyrate serves as a primary energy source for colon cells and reduces cancer cell proliferation. Can also trigger apoptosis, which is programmed cell death. Basically, the cells self-destruct if they're damaged or cancerous. So butyrate, which is produced as a result of you feeding your good gut bacteria soluble fiber, helps decrease your risk for cancer. And fiber in general is good for your health as well. Outside of colorectal cancer, it helps to reduce your risk for cardiovascular disease and helps to prevent type 2 diabetes, which also indirectly reduce your risk for colorectal cancer. It's also good for other types of bowel disorders like diverticulosis. It's very common in the population due to a lack of fiber in the diet, and that can have its own set of complications. Helps with constipation, of course, moving things through. And soluble fiber kind of helps absorb things, and insoluble fiber carries it through. So how do we get more fiber in the diet? Contrary to this kind of cartoon here, you don't want to just go home and start eating heads of lettuce right away. That's not something that you're used to. You want to kind of gradually incorporate it into your diet because it kind of causes bloat, but your body can adjust as you kind of get up to those minimum standard levels. So the dietary guidelines are that we all get around 28 to 35 grams of fiber per day. For men, that's a little bit at the higher end of the spectrum. For women, you can cut a little bit lower, but this is the minimum. And most people are not meeting this minimum standard. So we'll go through, I think you all have handouts that kind of list some high fiber foods in case you need some ideas for that. Those are things that are, fruits, produce, nuts, things that are not typically packaged and have nutrition labels on them. You can always find them on the USDA website. For packaged foods, if you look at the nutrition label, you'll see under total carbohydrates, there's a line for dietary fiber. And your goal is to try and find foods that have at least 5 grams of fiber per serving. So you want to get that in one serving for it to be considered a high fiber diet. You don't want to find a slice of bread that has 1 gram of fiber and eat five slices of bread. That's not a good ratio. You want to find things that have that high concentration. So high fiber foods in general are going to be fruits and vegetables. They also have a lot of other nutrients and vitamins that are helpful, and antioxidant agents that help fight cancer as well. Whole grains, and then seeds. Seeds are powerhouses for fiber as well as other nutrients for our body. So you can look through high fiber food chart and pick out things that are appetizing to you, but in general, my suggestion, if you're looking to increase fiber in your diet, is not just to go to, for example, pistachios and say, oh, I get three grams of fiber with that. So I'm going to have what's 10 times a quarter cup. You're going to have 2.25 cups of pistachios a day. That's not a really great way to get that much fiber in. You're getting a lot of calories in with that, and you're not getting all the other vitamins and nutrients that come with these other food groups. So you kind of want to pick and choose from different food groups in order to reach that minimum 30-ish gram requirement of fiber. So how am I doing on time? Got about 20 minutes in. Okay. So I'll go over my breakfast then. This is what I've been doing for the last 10 years, and I can't say that I eat perfectly all the time. I like, pizza and burgers and fries and things that aren't necessarily great for you, but I do try to get a good breakfast in the morning. And I get 10 grams of fiber in with this. It's relatively easy to make out of time. We're all busy, stressed, but you can meal prep this. It's not too expensive. And I think it's pretty tasty. So you can mix and match with whatever you like to eat. But you can get about 4 grams of fiber in with just oats. And I know they sell those little oatmeal packets. There's a big difference between instant oats, whole rolled oats, and steel cut oats, apparently, when I did a deep dive on this. So you really want to be buying those oats in the most unprocessed possible, little additives, sugar, anything like that to be added to it. If you can get them in bulk, and steel cut oats are the least processed, that'll have a higher content of fiber as well as other nutrients. So right now I'm doing whole rolled oats. I do a half cup of milk with that. My milk of choice right now is flax milk. Doesn't matter what you choose. Cinnamon for some flavor. Chia seeds. Chia seeds are a powerhouse. I've been adding them for a while. I consider it medicine because it has good omega-3 fatty acids in addition to that fiber. If you get a full serving of chia seeds, that's 10 grams of fiber alone. That's about 2.5 tablespoons of chia seeds, which I feel is overwhelming, so I just do the one. And then you can pick whatever fruit you like. I think apples are easy. You want to get the skins as much as possible in with your fruits because that's where a lot of that fiber and nutrients is. It gives you good roughage for your colon, and it's where you actually have some of that insoluble fiber that's present in fruits and vegetables as well. Berries are great, have a high source of fiber in there, and oatmeal. You can add whatever else you like, but that's a great way to start the day if you need an idea for how to incorporate more fiber into your diet. That's what's worked for me at least. What other dietary changes can we make to reduce the risk for colon cancer? One of the things that's been studied quite a bit, doesn't have quite as definitive a link to colorectal cancer, but there's been a moderate amount of evidence for it, is red meat and its association with that risk of colon cancer, and especially when it's more highly processed. So your char-grilled meats, deli meats that have a lot of additives, preservatives, bacon, sausages, hot dogs, and then any salted or smoked meat. So it's not just necessarily red meat, but that meat might be processed, even if it's chicken, pork, fish, things like that. The more processed it is, the higher content of carcinogens might be present. Red meat is thought to increase the risk for colorectal cancer via the heme iron that it contains, which causes cellular damage, DNA changes that can increase the risk for colorectal cancer. When our gut bacteria process meat, they produce a gas called sulfine, which is carcinogenic. And then the last thing that is thought to contribute to that increased risk are nitrates, which are used as a preservative for a lot of meats and are processed to these N-nitroso compounds that also damage the lining of the gut. Another modification we can all make that has been studied are processed foods. So the more highly processed foods that contain added sugars, oils, or again, preservatives in them. These have all been not only associated with the risk of colorectal cancer, but are also tend to be void of any nutrients or bioactive compounds that are beneficial to our health. What are organic foods? That sometimes comes up. So the data on that is not as strong. There was a pretty large study out of Denmark, actually, where they didn't find any improvement in colorectal cancer risk with organic foods. They do tend to be more expensive. So questionable whether it's always worth the cost, but they have looked more on a biochemical level at the concentration of pesticides in excrement, for example, and the antioxidant concentration within organic foods compared to conventional produce, and food is actually much higher. So theoretically, and borne out in some studies, is an improvement in your risk for cancers in general, but in specifically colorectal cancer as well. If you want to kind of transition to organic foods, but maybe can't do it across the board, you can look up the Dirty Dozen, which are fruits and vegetables that are known to have the highest level of pesticides on them. And these are the things that you would suspect because they don't have thick skins or peels that you can take off. So berries, your greens like spinach, kale, for example. If you want to start getting some things that are organic, those are the things to look at first, the Dirty Dozen. Yeah.
Do you have like a relative risk of eating red meat versus a non-red meat eater for developing colon cancer?
Yeah, that's a very good question, and I'm sure there is, and I just don't know it off the top of my head. Yeah, so I apologize for that. And then the last thing you can do with your dietary modifications, which will extend to managing your weight, is watching your portion size. So again, people sometimes hear about foods that have high nutritional value, and then they kind of overdo it in general. Look to moderate all things, even if they're good for you, and eating only what's necessary so you don't have excess calories is important. So we'll move on to the next thing here outside of diet. A major risk factor that's emerged for increasing the risk of all types of cancer, not just colorectal cancer, is alcohol. And The idea in the past, there was this idea that a moderate amount of alcohol might actually be healthy. In particular, there were studies on red wine, and the benefit thought to be from resveratrol and flavonoids that were in the red wine that act as antioxidants to help reduce risk of cardiovascular disease. But more recently, multiple medical organizations have come out to say that there really is no safe amount of alcohol. At the end of the day, alcohol is a toxin and a carcinogen. The reason is because the body converts it to acetaldehyde, which is a potent carcinogen and damages DNA and other cellular components, and thereby can increase that risk for cancer. It also alters your gut microbiome, so it makes it easier for carcinogens to penetrate the cells that line the colon and impact them that way. And so it has been associated, especially heavy use of alcohol, has been associated with an increased risk of colorectal cancer. In addition, it affects other parts of your body, as we know, the liver, of course, but also cardiovascular disease, hypertension, and other cancers such as breast, pancreatic have increased risks associated with heavy alcohol use. As I mentioned, weight management is important. This is a large meta-analysis that came out looking at 66 different studies. It has some flaws to it, but the overall messaging is still there that obesity and carrying excess weight does elevate your risk for colorectal cancer up to 57%. So the reason being, or at least the hypothesis reasons being, that obesity is pro-inflammatory state, fatty tissue, especially around the gut, where some people tend to store it more, also known as visceral fat, secretes a number of inflammatory cytokines, and that creates a systemic inflammatory environment that's ripe for the development of cancer. This chronic inflammation can lead to DNA damage and promote the growth of colon cancer. And then the other mechanism by which obesity can increase that risk is by increasing the risk for type 2 diabetes. And with that, we see insulin resistance, increased circulating level of insulin, and insulin growth factor. And that is what's thought to be the link between type 2 diabetes and colorectal cancer, is really the insulin growth factor is directly stimulating cancer cells, but also creating this tumor microenvironment that can contribute to cancer development and progression. So just in quick review here, 5 healthy habits for prevention. Number 1 is to think of your food as medicine, and what are the nutrients and vitamins that you're getting to your body, to all the cells of your body when you consume your food. And we're not perfect, but we do want to concentrate on things like fiber, minimizing processed foods, and choosing plant-based alternatives when possible. I'm not vegetarian or vegan, but try to go maybe 1 day a week without meat, for instance. You can gradually incorporate some of these changes. I didn't touch on smoking because most people know that smoking is bad for you, but most people associate smoking with the increased risk for lung cancer and realize that it increases the risk for cancer across the board, really. But colorectal cancer as well. So it is one of the best things you can do if you are a smoker, is to stop doing that. Minimizing or eliminating alcohol altogether, maintaining a healthy weight through diet, as well as exercise. I didn't really touch on physical activity, but that obviously goes along with overall health and reducing that risk. And then lastly, getting screened, which is part of stop. So colorectal cancer screening can give you peace of mind that your colon is healthy and you have the control to keep it that way. Even if you're found to have a cancer, sometimes it'll be caught at an early stage when treatment is not only most effective, but you can also avoid potentially additional treatment like chemotherapy or radiation. If it's early, sometimes we can just do surgery and be done with it. So what are some reasons people don't get screened? We saw that we're not meeting that national goal of 80% getting people screened. So some reasons for that would be the perceived benefits to colorectal cancer screening. It doesn't always feel like a priority to people. They're busy, especially when they're younger, and have kids, family, busy lives, work, that kind of thing. And if you're feeling well, it's probably not the list of priorities. There can be real or perceived barriers to action, such as cost, especially for people who don't have insurance. It can be a very expensive exam if you're looking at a colonoscopy, but as I'll discuss, there are some cheaper alternatives to that. Transportation, if you are getting one of the invasive exams, time off work to have that study done. And then lastly, the perceived susceptibility to colorectal cancer. A lot of people think, well, I don't have a family history. I don't have any of these other conditions that increase your risk. So, and I really don't have any symptoms. I'm probably fine. I'll just put it off a little bit down the line, a little bit down the line. Just remember, by the time you're developing symptoms, you might already be looking at a more advanced stage of cancer. It takes a long time sometimes for cancers to become symptomatic. So changing those beliefs and informing people is to increasing our screening. So what are the current screening guidelines? As I mentioned, 45 is the new 50. So everyone, regardless of your personal risk, should be screened between the ages of 45 and 75 every so often, whether you're choosing a stool test, imaging study, or colonoscopy. High-risk patients may start earlier. So if you're one of these people with a strong family history, you may start screening at 40 years old or 10 years before the age of diagnosis of your relative. So if a mother was diagnosed at 42, you want to get screened at the age of 32, and then every 5 years thereafter. If you are known to have one of these syndromes, familial adenomatous polyposis, they get screened starting at a much earlier age. Lynch syndrome, patients with IBD, they start getting screened to much earlier because they have such an elevated risk, and they get screened almost every year because of that. And then for patients after the age of 75, what do we do with them? I do get a lot of people coming to me saying, well, my doctor said since I'm 75, I don't have to get screened anymore. But the truth is that's sort of a gray zone, and you have to look at the patient as a whole between the ages of, and kind of gets pushed a little bit later and later. But 76 to even up to 85, I would say if you have a healthy person, very functional, good quality of life, few other medical issues, and they have a guideline would be if you think they have at least a 10-year life expectancy, I think there should at least be discussion about screening at that point. That could be based on the patient's preference as well, and their overall health and priorities at that time. But it shouldn't be just automatically dismissed because of their age. So what are some options for screening? We do have the colonoscopy, which I'll talk about a little bit more, but as this cartoon suggests, you do have some options, not pumpkin spice colonoscopies, but stool tests and imaging studies. So there's a couple of different stool tests, the fecal immunochemical test or FIT test, and guaiac-based stool test. They test for occult blood in the stool. That's blood that you may not know, but is due to red blood cells that are being shed by any number of things in your colon. It could just be something benign like hemorrhoids, but it could also be a polyp or colon cancer. And these stool occult blood tests will often pick up on that. They need to be done annually if they're done as the sole screening test, but they are good options. And then there's Cologuard, which I'll get into the details of a little bit more. It's more sensitive than the test looking at just blood in the stool because it also tests for precancerous DNA. And so that frequency of testing can be extended a little bit to every 3 years. Imaging studies include CT colonography and barium enema. I actually just spoke with one of the radiologists who mentioned that we don't actually have the barium contrast right now, but we're looking at getting CT colonography up and running. So hopefully we'll have that available down the line, because we do occasionally use that for patients when we can't get through their entire colon. Some people have very difficult anatomy. And if you're already prepped for your colonoscopy and there's availability in radiology, sometimes we'll send them down for barium enema if we can't complete their colonoscopy. If you do have one of these imaging studies, they're recommended every 5 years for screening combined with an annual fecal occult blood test, but they do also require bowel preparation. That said, they tend to be a little bit less invasive than going through a colonoscopy. You don't have to go into a hospital, go under anesthesia, and potentially expose yourself to the risk of colonoscopy, which despite rare are present. So going back a little bit to the Cologuard here, I do want to talk about this because I prefer this as sort of my main alternative when patients don't want to have a colonoscopy done. It has a very good sensitivity for detecting colorectal cancer, not so much polyps, but colorectal cancer. And it's pretty easy for patients to do. It's usually covered by most major health insurance companies as well. So it tests the stool for both blood in the stool and precancerous DNA that might be shed by polyps or cancer. It's considered non-invasive and can be done from home. There is a rate of false negative and false positive results. So sometimes you can have hemorrhoids that are bleeding and turn the test positive. Or it might be falsely negative, and unfortunately, for whatever reason, you have a colonoscopy in a year for an episode of diverticulitis, and we do find that you have some polyps that might have been missed by the Cologuard test. So it's not a guarantee, but it has pretty decent sensitivity for the more advanced pathology. If you do have a positive test that goes for both Cologuard and any of these other screening tests, then a colonoscopy is indicated to take a direct look at the inside of your colon and potentially treat any polyps or cancer that it might have identified. Cologuard is not typically recommended for patients who fall into a high risk group. We want to use the gold standard, which is your colonoscopy for those people. So if you have a family history or personal history of adenomatous polyps, you should be looking at a colonoscopy as your screening test. If you've never done the Cologuard test or don't know what it looks like, this is from their website, but it's actually pretty easy. They mail you this box and it comes with a carton here that kind of fits into this tray that you put right over your toilet. So you can go right into that carton. You take a small sample for one of the tests that they'll process, and then you'll fill the rest of the carton with this fluid, top it off, and then mail it back to them. It does feel a little weird to be mailing your poop, but at the same time, it is effective as a screening test. So if you don't want to get a colonoscopy, it's there for you as an alternative. So colonoscopy, as I mentioned, is the gold standard. That is because it has the highest sensitivity. It's not perfect. It's not 100%. We can still miss very small polyps, especially if your prep isn't adequate. But it is the best way for us to look for polyps and colon cancer, and we can also identify other pathology when we're in the colon. It's the only test that's also potentially therapeutic. If we do see polyps, we're typically going to try and remove them as long as they're not too large at the time of the colonoscopy. By removing those polyps, we can potentially prevent you from getting colon cancer. It's usually done under anesthesia, and that can be twilight, where you're sort of in and out of anesthesia during your procedure. Or here at Verde Valley, we have anesthetists who will give you propofol and monitor your heart rate, blood pressure, breathing while you're undergoing the procedure. So you're really quite comfortable. And that ends up being the easy part. Most people will complain more about the bowel preparation, of course, where you have to starve for a whole day the day before, and then on top of that, flush your entire system out. So it's not the most pleasant experience, but I am told you get a little closer to God. And then lastly, the risks of the procedure are bleeding and perforation. They really aren't very common. The reported risks in the literature are 1 in 200 cases result in bleeding, and 1 in 1,000 cases result in perforation. Anecdotally, in my experience, I find that that risk is usually much lower, and if it does happen, it's usually not too severe. I tell my patients whenever I go over these risks with them, as I say, there are risks. It's important to be aware of them, but also know that if you experience any of these complications, we will take care of you. So hopefully you feel like you can trust your providers who are doing your procedure. There's some risks to the anesthesia as well. So there's some patients who I don't recommend that they have a colonoscopy because they do have medical issues that are too significant. Either they're on too much oxygen, they can't breathe adequately, they have heart conditions, and even a little bit of anesthesia can potentially cause cardiopulmonary complications during their procedure. This is kind of what it looks like, the setup when we do colonoscopies. So the patient is usually laying on their left side, and the colonoscope is sort of this flexible tube about the diameter of my thumb. It's obviously very long to be able to get through the whole colon. 6 feet long. And we kind of snake it through the entire colon. I'd have to say it's probably the hardest procedure I had to learn how to do as a surgeon. And so our goal is to get from the beginning here at the rectum, get all the way to the cecum here, the very beginning of the colon, so that we make sure that we see everything that we need to see. The end of the instrument is actually pretty busy and has a lot of tools for us to use. Aside from the camera, we have some light to illuminate what we're seeing inside. We have a irrigation channel that also insufflates the colon with either air or carbon dioxide. So that way we can really spread everything out and see around all the folds. There's a suction channel so that if there's any residual fluid in the colon, we can suction that, clearly see the walls. And lastly, there's an instrument channel through which we can put forceps, which are pictured here, that can pick off small polyps, snares, which are like lassos we can use for larger polyps. They can be hooked up to cautery to help minimize the risk of bleeding. There are clips that we can use to help close defects after removing large polyps. So there's a lot we can do with this instrument. We're seeing the inside of somebody's colon. This is kind of what it looks like. This is a normal colon, and this is probably transverse right here. Both of these upper ones kind of has that triangular look to the inside of it. Has all these folds through it, so it kind of looks like an accordion. That can make it a little bit difficult to examine. So we really take our time trying to look around all the different walls of the colon. But it is one of the ways we can sometimes potentially miss smaller polyps if they're hiding on the backside of those folds. This is the very beginning of the colon here, and we know that by this kind of yellowish, fatty, thickened fold here, which is the ileocecal valve, and that's where the small bowel dumps into the large intestine. So colon polyps can happen anywhere from the rectum through to the cecum, and there are different types of polyps. The one up here is a pedunculated polyp. It's on its own stalk. Those are a little bit easier to identify and to remove because they're kind of protruding out into the lumen, so you can easily see them. But these types of polyps, which are kind of, they blend into the colon wall, they're called sessile, and they can be easier to miss, especially when small or similar to the color of the colon lining. So when we talk about polyps, we know that as polyps increase in size, so does the risk of them harboring colon cancer. That's part of the reason we try to get to people and screen them early. So we find them before they develop colon cancer within them, somewhere at this stage, even if they're a little bit larger. If we can still get them out of, below 2 centimeters typically, then there's a lower risk of bleeding and perforation when removing smaller polyps. And then lastly, this is just a comparison of the sensitivity of those different tests. As I mentioned, your colonoscopy, which is featured in these bars right here, has the highest sensitivity. These different colors correspond to sensitivity for colorectal cancer and adenoma, polyps of different sizes. And so even for the smallest size, which is less than 5 millimeters, colonoscopy is still pretty sensitive at 75%. It's telling me that I'm done. Your stool blood test, which is your FIT test, and your fecal occult blood test have much lower sensitivities. And then your Cologuard, which is your FIT DNA test, has a very good sensitivity, as I mentioned, for colorectal cancer. But then when looking at polyps, especially your smaller polyps, that sensitivity drops off. And the CT colonography is decent, somewhere in the middle there. But typically, my suggestion to most patients is if you're going to go through with a bowel preparation and you don't have any contraindication to going under anesthesia and you have, a day to take off work, if you're going to do that whole bowel prep, you might as well get the best test possible, which is your colonoscopy. So in summary, if you're going to take anything home from this presentation, that's that colon cancer is being detected at earlier ages. So for anybody around you in your life, 45 years old or older, has been screened and is up to date one way or another. You can decrease your risk for colon cancer, and if you're gonna take one of those modifiable risk factors to work on, I would work on your fiber intake. The minimum again is 30 grams, but you can even go more aggressive. There's actually a dose-dependent relationship between fiber and your risk for colorectal cancer. So the more you get, the lower your risk. And then lastly, early detection is key to preventing and curing colon cancer. So if you're due for your screening and you haven't been screened yet, please go do that and tell your friends and family to do so as well. Any questions?
So if a patient has adenomatous polyps, what do you recommend for frequency of surveillance, and does that last for the rest of their life? Or if you find none the next time, does it change?
That's a good question. So if you've ever found adenomatous polyps, then we do take that into consideration for future screenings. But take that with a little grain of salt, and those recommendations changed with time. But in general, it's going to depend on the number of adenomas, the size of those adenomas, and then the type of adenomas, because they do progress. They might have dysplasia associated with them. They might be tubulovillous and not just tubular. So different types of adenomas are also associated with different levels of risk. So depending on the number, size, and type, we will have different recommendations. The most frequent is generally about 3 years. That's if you have more than 4 to 5 adenomas that are small. If you have a larger adenoma that's greater than 1 centimeter in size, we're going to be recommending that you have a colonoscopy every 3 years. And if you have adenomas that are tubulovillous or have dysplasia associated with them, then that's also going to be a colonoscopy in about 3 years. It also matters sometimes how we take this out, how good our confidence in your screening was. Did we get really good views? How was your bowel prep? So we take all of those things into consideration. It's not just looking at the chart and saying, well, I only had one 5 millimeter tubular adenoma. Why is my doctor telling me I have to come back in 3 years? It might be because they didn't get a good view all around because your bowel prep wasn't adequate. Maybe we're tolerating the procedure, so they had to kind of get you through it more quickly. Or maybe you had a larger adenoma, say 2 centimeters, and they didn't get it out all in one piece. They removed it in pieces. They may say come back in 6 months because they want to keep a closer eye on this spot. So it can really vary depending on how your procedure goes, not just the results of the polyp, what those polyps were. Other questions?
We do have some fiber-rich
Get you.
snacks. If you guys would like to have some, I asked Dr. Nagaraj, what should we have for refreshment? So she recommended hummus and vegetables, so celery, organic rainbow carrots, because I figured, colors important.
Yes,
Yeah.
absolutely.
I don't know about cherry tomatoes, but they look good on the tray. So, and then there's some nuts. So I figure we hit all the fiber groups. So feel free to take some with you.